have an important role to play. So I think, are they ready? I think Zai is ready. You can see her.
Yeah, we can see she's ready.
So are you ready on the... can we have the microscope view, please? Microscope view. Can we have the microscope view? No, the microscope view.
In a moment, they are doing it. I'm starting now.
Yeah.
2.2 millimeter incision. मावशी डोळा अजिबात हलवू नका अगदी स्थिर राहा I will be using intracameral oculan for her. Right now we have put parakin. She is anxious, so if she does feel that she is not comfortable with it, we can increase it with subtenance anesthesia.
Okay. Is this the last patient that you did?
Yes, the last one with the
Okay, okay. That's a very good idea that the patient, if the patient is anxious, let's complete the procedure in that patient.
Yeah. But again, she'll sit outside and think and overthink.
Yeah, yeah. So do you make incision on the axis, on the steep axis, or this is your preferred axis?
Synergy, this is not a toric patient.
Mm-hmm.
So since I prefer the acid superior at the head end of the patient,
Okay.
and the axis,
Yeah.
it comes at 135, the incision side.
Mm-hmm. We can see a free floating capsulotomy capsule.
Yes, yes.
Capsule.
So that's why I put visco first. Otherwise, sometimes it goes and sticks on the endothelium like a dissect flap.
Yeah.
थोड़ा मशीनचा आवाज आहे ना थोडा जड वाटेल better to eat up the capsule first.
So our pieces are very much separate already, and what I can figure out is that Dr. Jai is separating a couple of ones while holding also very well. And the whole nucleus will get emulsified. In the same, I think, in few seconds only, Dr. Jai.
Yeah, exactly. So this is power up to about 5.
The duration of femto laser was almost same as the duration of your emulsification.
That was quick work, absolutely, and the pupil is mid dilated.
Yeah.
Yeah. So can we make it a little retro, because then we can possibly see the glow? Yeah. The microscope is fantastic, Zai. I believe this is a Bumera microscope.
No, this is the Zeiss.
Right.
Other center.
Nice. Yeah.
You see Dr. Aditya and Dr. Pankaj.
And you like to do a bimanual? I think that is advocated, especially for FLACS cases. It always, is useful to do a bimanual rather than a coaxial.
They asked me to use the coaxial. I'll have to learn it.
Okay. So we all began with coaxial and then shifted to bimanual. For you all, possibly, you begin with bimanual and you stick to it. So which intraocular lens are we planning to?
We are putting the synergy.
Synergy, yeah.
I'll show you the lens parameters.
Yes.
In such a small pupil, it is particularly, bimanual is very useful.
Yes, and I think Zai is doing it absolutely effortlessly. You can't,
Yeah.
it's actually not so easy to do in a mid dilated pupil like this, but not mid dilated. This is a small pupil. I think it is hardly 3 or 3.5 millimeters.
The pupil does have a tendency to come down after.
Yeah.
Yeah.
So, do you preoperatively also use ketorolac or
Mostly no.
NSAID in these cases of FLACS?
Earlier we started using, but didn't find much of a difference.
Okay.
Are you using that?
I think we are using
We do.
non-steroidal anti-inflammatory drug, but I agree with you completely. Not that it makes too much of a difference, but the only thing is, suppose a pupil is small. Have you attempted a FLACS with a Malugan ring or with? Okay.
Mostly I find, would that be safe? Just take the patient inside, put the ring, again get him out of the OT again.
Yeah, that's very true. I think if the pupil is small, it is always better to go ahead without doing FLACS. But sometimes some people, they demand FLACS because they have gone through the internet information, and then in that case, on a couple of occasions, I've done it, but I don't advocate.
Yeah, I think that's an overdo.
We are putting plus 21 diopters synergy.
Okay. So synergy, as far as the material of the lens is concerned, it is the same as that of the Technis platform.
Yes, same. हलवू नका, डोळा थोडा दाबल्यासारखा वाटेल तुम्हाला.
And you are using the injector with a push injector or the one which has a screw in it?
One with the screw.
Okay.
The push one goes uncontrolled. This is a very controlled method. Screwing it in.
And what is the size of your incision, Dr. Jai?
It is 2.2 millimeters.
Okay.
Very nicely, effortlessly put actually. And that too single-handedly with the screw kind of a thing. Sometimes difficult to do it, but very nicely.
Yes, thank you very much.
So, right, you actually demonstrated a small pupil phaco so elegantly and so nicely.
The inadvertently. दूसरा भी रेडी Here I make only 2 incisions. If the pupil is sometimes the iris is floppy, then sometimes I make 2 incisions for the irrigation aspiration. Otherwise, it's the main port and the side port always.
Okay.
It works well. No, but there's no heroics in that. If the safety is compromised, then I don't hesitate to make another incision with a side port. Thoda khali bata.
I think Synergy is a great intraocular lens which gives a continuous range of vision.
Yeah, patients are very happy with it. Of course, a good case selection as with all the high-end IOLs is there, but once we have explained what to expect and what not to expect, 95% of patients will not complain. They will be very satisfied with the outcome.
That's very true.
Yeah, so though this lady was very anxious in the beginning, she allowed me to operate under topical anesthesia. And yes, so that finishes this.
Wonderful.
I see that you use a speculum which has a solid plate, and then is this the one which you use always?
Yeah, we use this speculum always, yeah. It has the screw, you can adjust it, and if it's becoming too tight, the lids are too tight, then you can actually loosen the grip and reduce the pressure on the lids. चला झालाय, पट्टी लावते थोडा वेळ. तुम्हाला सगळ्या बाकी सूचना सगळ्या बाहेर देऊ, ड्रॉप्स वगैरे अगदी व्यवस्थित झालं, काही काळजीचं नाही.
Friends, do you what is your experience with the speculum? Have you patients are satisfied, or that they need some kind of a spectacle, or Again, like you said, patient selection is very important in such cases. For which type of patients would choose this lens?
Who have a lot of night driving, then there is some amount of glare till the neuroadaptation occurs. So we will not give them to people who are in a habit or are professionally drivers, or they have to drive, especially on the highways when the blast is full on the light. The people are driving on full beam because unfortunately in our country nobody is going to drive on the low beam. But for housewives or patients who are retired who do not want to be dependent on glasses, people with say tremors, Parkinson's, all of them have a lot of, we can say, they are very happy if they don't have to depend on glasses for their reading. I operated my father last year, and earlier he used to be a voracious reader, but as presbyopia and later cataract set in, he just kept his books and reading material away. But with Synergy, he actually has a symphony which also works very well. He is back to reading. So always think of that. If you are a voracious reader, then yes, these lenses are definitely for you.
I can see that you have patched the eye, and many people they say that we don't do that, we don't patch.
Yeah.
We also prefer patching the eye immediately after surgery for a couple of hours, and then only once the patient reaches home, then the patient removes the patch. This is what I feel personally.
No, but there was a time when we had totally given up patching the eye. We used to put goggles directly on table. Then there is some amount of comfort in your mind if you patched it for at least till the anesthesia wears off. It's better, I think.
Yeah, and the patient goes. These are all daycare procedures. The patient goes home, and in between, there can be some dust, etc., whatever. So, for a couple of hours, maybe.
And most patients prefer to put a patch. They feel better. Raghu, you put a patch, nice. The way they should not no patch, just goggles.
Yeah. They are also scared.
They are also scared. Yeah. So all said and done, we are after operating in India. There is a lot of dust and a lot of pollution and hygiene issues. The Western world is not putting glass patches. Doesn't mean we can follow. So the next case is a toric patient. But it is already about 5-10 minutes since we did the femto, so maybe the pupil, I am hoping the pupil has not come down.
What toric are you putting? Technic toric?
It's a technic toric case.
Technic toric they don't have yet in the market. They should come out with energy toric and ocular lens also. Rajesh, you've put lenses on the toric platform across all manufacturers.
Yeah.
What do you think? How do they different? Do you think there's any difference, between the lenses as far as the rotation is concerned?
No, not much of a difference. If you do, 1,000 cases, then you will get some difference in rotation, and as such rotation in hydrophobic lenses is negligible. So if you have placed the lens in its position and you have removed the viscoelastic from behind the lens, then the lens, the back surface of the lens is in a good apposition with the capsule, and hydrophobic surface has a good adherence with the capsule. So most of the lenses, they remain in position, and you do 300, 400 cases, and then you will require to re-rotate only in maybe one or two. So mostly, in most of the platforms, the lenses, they adhere well. They stick to its position well. What is most important is that the viscoelastic from behind the lens should be removed completely by going behind the lens and aspirating out completely. That is what I have felt.
We can see that they have at NIO Pune state-of-the-art operation theatre, and things are moving absolutely smoothly.
Yeah,
the way
very fast.
Yeah, wheeled in and wheeled out, and proper blood pressure, etc., being taken, and extremely efficient. And I think we really need to thank them for allowing us to peep into their operation theatres from the comfort level of our own houses without having to visit their operation theatre and their city in this COVID era. and
Yeah.
we are witness to excellent state of the art surgeries that are being done from NIO Pune, and that too on a Sunday. When everybody must have come to actually do these procedures.
Yeah. But I
Everything
think
is looking effortless actually, and for a thing to look effortless, a lot of effort has been done earlier. That's why that's the only way how things look effortless. So
no, but this is a
those
great
two.
initiative by AIOS, and actually the pleasure is ours. But thank you very much for the kind words. Right. काका डोळे उघडा बरं. नाही, उघडेच राहू द्या. आता आपण सुरू करू. हे डोळ्यावर
So the
चिकटवते.
whole team appears to be very efficient,
Yeah,
and
very
obviously the
completely
credit should go to the
done.
team leaders.
Yeah.
But it's
One
really
of the
the
reasons
participants.
being it's a Sunday, we don't have anything more lined up. So after this is done, we are planning on having a good, nice lunch. This is for him, I'll be putting a toric lens. So Chetan tells me the haptics for this particular lens are unpolished. That is something new which they have done so that the lens does not rotate.
Okay. Okay.
And he tells me they want to launch it very soon.
Okay.
Maybe it's available in Delhi. Things come slightly later in Pune. बरोबर लाईट कडे बघ ना आता हलू नको.
Can we have the microscope view, please?
थोडं खाली बघायचं.
Can the audio yeah, perfect. Excellent. Wonderful, wonderful view. We can see everything very clearly. Every single vessel of the eye is
Yes.
actually focused on our laptops.
Thank
So that is the beauty of the whole thing. It is like peeping from the viewing side view of your microscope. Maybe better than that.
So these are the callisto margins. Tells me where my incision will be. And this is the Z alignment, which will tell me how I'm going to orient the lens.
I think they need to show you. They need to show us the monitor, please. Can we see the monitor?
Yeah.
So put the monitor in the main view, and you can put this in the inset. You can put the monitor in the main view. Yes, perfect.
Yes.
So we can see now that there is a line which is going absolutely in the center. What is the axis in which you're going to implant the lens?
0 degree.
0 degree.
Yeah, 0 degree.
0 degree.
थोडं खाली बघ.
So we can see also the side ports and the main wound which you are likely to make in this case.
थोडं खाली बघायचं. नजर जरा खाली करा. बस, आता हलवू.
Perfect. So what I saw was that Zai, you made the side port and the main wound together.
Yeah, I do that.
Okay, okay.
So put viscoelastic so that the capsule won't be tempted to go and touch it and kiss the endothelium.
Now we can have the other view, please. The callisto work is done. Maybe we can use it later when we put the lens. Perfect. Now, wonderful. Every single, every single thing is so well focused. So do you do a very vigorous hydro procedure in these cases because
We just releasing bubbles when see a huge one down there. But the lens is already floating. Just tilt it and it all comes out.
Yeah. There's partial pneumodissection as well that is done. So I guess by removing the bubbles, gas bubbles, you can easily rotate the nucleus. Again, a wonderful free-floating capsulotomy. And
yeah.
Can we focus it a little bit? Can you take it a little bit towards you? I mean, we are seeing the speculum and we are seeing the eye. So we can just center it a little bit. Yeah, perfect.
हलू नका. थोडा मशीनचा आवाज येईल आणि डोळा जरासा जड वाटेल.
So the machine that you're using it is also White Star Signature Pro, which again is a great machine with excellent, dynamics, especially the AC dynamics, especially when you're doing phacoemulsification. The AC is really stable, and we can see that the pre-chops which have already happened because of the femto-assisted laser.
Very easily
Yeah,
separated, no?
yeah.
Pies.
You just touch them and they separate.
So what are the parameters at this point in time that you're using?
Now the phaco power is 10.
Okay.
The vacuum is 450.
So before we realize the phaco part is done only.
Yes.
So I think again a very wonderful demonstration of how the bimanual irrigation aspiration is done. So normally, Zai, you said you don't make the third pot, but sometimes you may need to make. So
The temperature doesn't stabilize then.
okay. So then, what percentage of cases you would actually need to make it?
Very rarely actually. If I have not had a good valve incision at the main port, then sometimes it's needed.
Okay. Okay.
If it's a uniplanar incision, then the chamber won't stay.
So I think this is a great advantage of a bimanual that your 12 o'clock. In fact, everything is accessible from
Exactly.
the furnaces. The pupil again is not very great here. It's not really too much enlarged. Maybe a shade better than
The previous.
our previous case. Just helps a little bit when you put the fluid, so it kind of gets dilated for you to see where the leaflets of the cortical matter are. But again, you did a great job, in that mid dilated pupil.
Bit of cortex.
This is a wonderful trick that you did, Dr. Jai. I really appreciate it. With the fluid that you dislodged, that there's some pieces that sometimes they get stuck behind the iris, some epinuclear material. Sometimes they get stuck to particularly in hard cataracts, they get stuck somewhere. And with the help of a jet of fluid,
Yeah, it helps.
it really helps, and it dislodges.
See a very small tip which is coming out. Usually it's a huge piece which is.
Yeah.
This is the lens.
Okay, so this is a Technis toric lens, like you said, with unpolished haptics.
Unpolished haptics, yes.
So that it does not rotate.
Yeah.
In the bag post-operatively.
आता थोडासा प्रेशर वाटेल.
And again, completely effortless. I think that was again a beautiful implantation of the intraocular lens. You like
advantage of this,
yes, sir.
The advantage of this unpolished haptic is also that they don't stick to the optic, and if a little roughened, then they stick to the optic and don't stick to each other. So that is the advantage. And also,
I think in the previous days we used to have this problem that the haptics have got stuck to each other or got stuck to the optics, and then it's another task to actually detach them from there. So can we now have the Callisto view, because I'm sure Zai is going to be putting the lens in position, and I think it's a great challenge, Zai, to put a toric intraocular lens into correct position through the pupil, which is not that dilated, and you need to see the marks. Can we have the Callisto one? Yes.
Here are the marks, and it's exactly overlapping.
Yeah, exactly
Yeah.
overlapping.
Yeah, so the trick here for all torics is that the visco should come out of the bag, otherwise there have
Absolutely.
been rotations.
Yeah.
But maybe with the unpolished thing, that also must be obviated now that they've come up with it.
So I think that was excellent. And again, just for a split of a second, the pupil did dilate to make us aware of the fact that, those markings were seen bang on the 0180. And again, wound hydration. Do you put moxifloxacin in your cases?
No,
Sai?
not
No?
putting.
Okay.
Initially, again, we did for a few cases and then stopped. We did that survey a few years back. Yeah.
So there was this AIOS survey which was done by Dr. Kelkar's group, Dr. Aditya Kelkar and Dr. Zai Kelkar, which looked at the people which asked whether intracameral moxifloxacin should be given or not, and in which conditions. And I think I think you are again going to do yet another one, because that was almost 5 years ago.
5 years back, yes.
So excellent, excellent case, right?
Thank you so much. Thank you very much.
Thank you. It was so effortless. I mean,
Yeah. That is the word, effortless.
effortless. Absolutely, you finished it. Like
Part of the credit is to you both also. You've been very encouraging because it didn't put
No,
a
no,
lot of pressure on me, but it was flattering.
Actually, we can encourage, but the work has to be done by you only. Finally, it's the work that is showing.
Yeah, no, it was just like an absolute
Just appreciate.
cakewalk. Yeah, cakewalk kind of a thing.
Yeah, you can just appreciate and do nothing. The work has to be done by you only.
You're both excellent surgeons, so coming from you is a big thing for me.
So I know that, I don't know whether many people know, but I know that Zai is a great athlete also, and she really is into athletics and marathons. Am I right, Zai?
Yeah, yes. So today morning, Aditya and I, we both had our run, but only because of this program, we cut it short. Did about 10 kilometers only. Okay, so I think Aditya is ready. So we'll start with the relay at Shivaji Nagar. So thank you very much. It was a pleasure, and I'll join you at Shivaji Nagar now.
Thank you so much. Thank you.
Thank you.
So again, this is a unique feature where from one